what are the challenges and policy issues that confront advocates on behalf of tissue and biospecimen collection? And we know that all tissue samples are looked at under a microscope, but it seems today that we need to complement that microscopic analysis with molecular pathology.
Right.
And we need to help patients understand this before they go in the OR. We also need to do a better job with calming surgeons who feel very controlling and often very territorial about it's their turf. And I've been through this personally, advocating for people where doctors wouldn't sign off on a patient request to send their tissue off to a molecular lab.
Where the patients wouldn't sign, or the
doctor wouldn't sign. On the flip side of that is now the abundance of companies that will say, send me your tissue, we'll do either, we can do mouse grafting with your tumor, we'll do your genotyping, we'll do your molecular analysis, and we can do chemosensitivity testing. And so now, as it's becoming an issue to separate fact from hype. So back to the advocates first to address how are we teaching people what they need to know about the value of tissue, and how are we also helping researchers get access to the very valuable tissue that they need to have in order to do their science.
What you're saying is absolutely totally true. We just finished the TCGA, which is a major federally sponsored program to look at primary breast cancer and analyze the DNA, RNA, and protein abnormalities. And we learned interesting things. You know, we spent a whole hour talking about what we learned. And it was all primary disease. I mean, nobody ever died of primary disease in the breast. Right. I mean, it's metastatic disease that really is the problem. You know, as a consequence of which, the Breast Cancer Research Foundation, an organization I'm very much involved with, has allocated a considerable sum of money, and more money is being raised to really support this kind of activity, to try to do a similar activity in people with metastatic disease, where we obtain biopsies, particularly in patients who are on trials of targeted therapies and other therapies, so we can correlate the benefit that they get, in this regard. And so because we've identified what we think is one of the primary problems is that nobody's willing to pay for a biopsy for research purposes. Right. And that if we can provide funds to pay for the biopsy for research purposes and also pay for the analysis of the specimens in the direction that you're talking about, that we'll learn something. But what we don't know is what is going to be the acceptance in the community of, it's truly on the part of the physician and the part of the patient, what's the acceptance of doing a biopsy of metastatic disease strictly to learn something. That may be of value to that patient at some point, but that isn't the intention. The intention is to learn something about metastatic disease in response to therapy. And I'm just curious about your impressions of what the acceptance would be if we had a program that actually paid to obtain the materials for research purposes with all the appropriate safeguards, et cetera, whether this would actually get off the ground.
There are a lot of patients actually that have talked about that on chat lines and everything else. They're very interested in donating tissue. They just don't know where to go and what to do. So if there was a program out there, we could certainly post it on our websites. We can get it on the different discussion boards. We can certainly make it known, and I do think that there would be quite a few volunteers. There are some that probably wouldn't want to do it, but I will bet you a significant number of patients would be very happy to donate tissue under those circumstances.
I'm part of the Translational Breast Cancer Research Consortium, right. And the advocates there have really tried to get across to doctors the idea of just ask the patient and you will find acceptance. If it can be explained. I mean, we know, I think we're as advocates, we're confident the doctor is not going to ask for a biopsy in somewhere that it would be really unsafe. But if it's possible to get a piece and they're part of a clinical trial, and they want to take another piece out for research purposes, we feel very confident that patients would agree to this. And among the metastatic groups of people that we have a national conference that you hosted, one of our very first one, and we're very appreciative of that. But people want to move the science ahead, move the research ahead, and affect the clinic. So I think with education, the answer would be yes. Doctor, do what you can, and I want to help.
Thank you.
I would go back to earlier you said about the importance of advocates being involved in developing clinical trials and the clinical trial design, and that's been my experience. I've been, as personally and as an organization, been involved in helping to design those trials and be that patient voice to say, yes, ask us for that biopsy because we know how important that is, and realize that we maybe need to go beyond that to the public. So before someone is diagnosed with cancer, they begin to have that idea in mind of the importance of tissue for research. And we've been having some meetings recently discussing the importance of tissue and how do you get that out, because when a person's diagnosed with cancer, there's so many things going on in their mind at that point in time, they may not be able to think through all the pieces of it, and that may not be the best time to ask them. But as we begin to educate our country about the importance of cancer research and how important human tissue is, we can't rely on cell lines and mice for everything, that perhaps we will have an easier time of getting that done. And often it is true, doctors won't, or whoever's putting the trial together might say, oh, we can't ask for that extra biopsy. And yet the patient community, I think for the most part, says, yeah, go ahead. It might be an issue about the payment.
That's right.
Because you have to look at those pieces of what the cost is to the patient involved in the trial. But I think it's very important to include that, and have enjoyed being a part of putting trials together so that you can put those things in.
How about tissue already removed? Can that be used?
Yeah, very often you have tissue on initial diagnosis, primary disease, so obviously you have that in the case. But in metastatic disease, sometimes you get tissue, sometimes you don't, sometimes it's dangerous to do a biopsy. But what we really need is we need sequential samples. We need people before you know, if you've got a drug that attacks PI3 kinase, you're going to want to know what the PI3 kinase status is before and what happens to it under treatment.
Got it.
We're shooting in the dark a lot, and you know, that kind of information can be extremely, because it may need more than one biopsy to get that information.
Sure.
Obviously, we'll do it, you know, as carefully and as safely as possible, you know, to get that information. But it's critically important that we do that, and I'm very encouraged by what I hear about the acceptance of such a program.
At Living Beyond Breast Cancer, since we do so much programming in the metastatic community, I think the wide acceptance that you've heard, Larry, so far, is also what we hear too. Being engaged in the research process, being able to participate in meaningful ways that not only will impact that individual, but also the thinking that it might help my loved ones and family members. Who knows if cancer comes into their life. So I think being engaged on some level in the research process with, of course, the informed consent of the possibilities, I think cost at the end of the day, which you're hearing, is really what's going to weigh the heaviest on the mind, not the cut, not the biopsy, not the possible side effects of that procedure, because I think the potential benefits could be enormous in terms of what we learn.
I want to say something really encouraging about metastatic disease here, and I think this is really important, because this message is not getting out for the most part, all right? And there's a whole lot of reasons for that, too, is that, you know, I mean, I'm thinking about, you know, I was at the bedside of a patient when a young physician walked in, you know, was trying to show empathy, and basically, I was sitting there quietly, and actually I was wearing a suit, so I thought I was a family member, you know, so in that kind of regard, and explained something, and then he finished it saying, I know it's a very hard decision, I'm sure I'm glad I'm not in your situation, as a way of showing their sympathy for the situation, you know. And I can give you dozens of stories like that as well. So you know, there's doctor-patient communication issues and nurse-patient communication issues. Nurses are much better, by the way, than doctors are across the board, you know, in terms of these things, but that have to be dealt with in terms of this. But I have people with metastatic breast cancer that I've taken care of for 25 years or more, all right? And every doctor has had a lot of experience and has individual patients with metastatic disease who've done extraordinarily well. You know, with conventional therapies, 25 years ago, that's what we had. You know, chemotherapy, hormonal therapies. You know, conventional kinds of therapies. The difference between them and the ones who don't do well could be single molecules that could be targeted. So Jose Baselga, who's just come to Memorial Sloan-Kettering, you know, as physician-in-chief, you know, who I was involved, honored to say I was involved in the training of many years ago, has clear evidence that that patients with HER2-positive disease, just presented, you know, HER2-positive disease, may not respond best if they have certain kinds of mutations of this PI3 kinase gene, but there are drugs that can attack the pathway from PI3 kinase. And when I heard this presentation and discussed this really, subsequently. I mean, I was sitting in the audience when I had just left the National Cancer Institute, and I had a young man with testicular cancer who was very sick with a lot of metastatic disease and was essentially on palliative care at that point. And I was sitting in the audience at a meeting when Larry Einhorn presented his data, and he said that, you know, if I just add cisplatin to the regimen, we had tremendous responses. And as I've told Larry Einhorn many times, I remember the seat I was sitting in. I had such a powerful image of the room when I sort of heard that, because I left the meeting early to go back to Bethesda. In those days, we didn't have cell phones and email and whatever, too. And we gave the patient cisplatin, and he had a fantastic response, unbelievable. And had I not been in that room at that time, hearing that point, now obviously we disseminate information in a much more efficient fashion at that point, but single drug making a dramatic difference for an individual. You know, I remember when everybody with Hodgkin's disease died, all right? And then I remember when curative therapy got developed and people get cured of it. Testicular cancer, we already talked about. Childhood leukemias, dramatically high cure rate. I wasn't around for gestational choriocarcinoma, which is the first cancer cured by chemotherapy, but that was the only one when I got involved in the field. Things can happen for good very fast. And for some individuals, it's already happened good for very fast for those individuals. We have to find out why.
Yeah.
And we have to get everybody into that category. So this concept that, you know, and it's part of what you have to say to be politically correct now, you know, don't expect major breakthroughs. It's all going to be incrementalism. There'll be, you know, 2% benefit, 3% benefit, and eventually they add up. The history of oncology, the history of medicine, it's not been like that. The history of medicine is you make slow incremental improvement and something happens and boom. And that, and there's every reason to believe that we can do this now in metastatic breast cancer, you know, and I think that, you know, I clearly make the prediction now that some people who have metastatic disease right now are going to be alive long enough and science will progress more enough that they will be cured. You know, because you know people who go for can go for long periods of time, you know, with modern therapy, and if science advances properly, we will find out, you know, what we can do to put them into that curable category. So this is a time to be energized and not sort of pull back and say, well, you know, I'm going to concentrate on other issues and not be aggressive about fighting this and not be not get involved in trials, you know, not let myself re-biopsy. This is a time to be very, very enthusiastic, because the outcome could be really, really terrific, all right, if we all, you know, group together, as we do, as we try to do, and if we get adequate funding into the mix, so that we can really make things, you know, move in a fashion. So I just wanted to make that positive comment.
Knowing your stature and your influence, I hope that younger physicians who are new to this environment would hear that, and rather than immediately tell the patient, you better get your affairs in order because this does not have a good outcome. I mean, right off the bat, that's a whole different viewpoint. And not that we give false information to patients or false hope, but if we can change the mindset of clinicians to demand more and to expect more and to, as you are doing, working harder every day, that's where the wonderful things will happen.
I want to, I guess, echo the comments of the panelists. As a metastatic breast cancer patient, we are involved in so many trials designed to benefit primary cancers, primary patients, first time out. The idea of being involved, tissue samples, or whatever it takes to make an impact on metastatic disease is something I would readily step up for, and I am quite certain I am not alone. We are already stepping up when it comes to primary disease trials. So.
And going back to the tissue collection, I just want to mention, especially for the metastatic patient, that that sequential biopsies of recurrent disease is so important. Because lots of times we're treating patients on their original biopsy, and the mutation is patients are having cancer within the cancer. The disease in the lung may be different from the disease in the groin, and I think that people are afraid of getting biopsy. So I think if the morbidity is low, I usually always encourage the patient, well, you want as much as information of your tumor today, not the one that you had 12 years ago. So it's really important to get that information and to pass on, and I just keep them going until one day we'll just turn the switch on, it will be all gone. And I really firmly believe we're going to be talking about breast cancer like smallpox and like polio. I mean, when polio was, people had 2 or 3 people on the block with polio or smallpox. I mean, now, when was the last time you see a new polio victim? So I think we just keep on going with our research, and I think the contribution of the patient and the advocacy, I think we just have to continue to do research. And I think tissue collections and do research is very, very important. And we should not be afraid. And I can tell you, in my group, there are physicians that would not offer that second, like neoadjuvant breast cancer therapy, that we have a trial, they get a second biopsy. And about 80% of my partners, they just feel, I just feel bad asking for the second biopsy. They don't even ask. As opposed to say, listen, we need more information about tumor. If you explain to the patient, we're just getting more information about something that may help you. So I think we need to talk more to the people and to the patients.
I had an early stage, 12 years later, a couple spots in my spine. The biopsy showed that my molecular type was different than my primary, but my oncologist then discounted it, started treating me as if I was still with the molecular type early stage, and the breast cancer then spread throughout my skeleton and into my liver. I changed oncologists. That one got a biopsy. My whole molecular type was different, got a treatment personalized for that molecular type. I went into remission, and I have been living now 9 years with metastatic disease. So I was following what he said, don't worry, you know. So I think, I know the experts, as yourself, have really encouraged other physicians to consider the necessity of a biopsy years later, and that is a wonderful change, and we have tried to get that out as an advocate community. So you're right on target.
To allow patients to feel a sense of excitement that they can be a part of change, the paradigm shift, and to bring meaning, and not to underestimate the importance of bringing meaning and value to their cancer experience, to make it count for something. And thank you to all of you for making time to spend with us.
Thank you. Thank you for inviting me.